Hello, everybody. Welcome back to webinar number 2, where we're talking about metal hypersensitivity in orthopedics. We have with us 3 experts who are going to give us a 5-second introduction of each of them. I'm Steve Kurtz. I'm research professor at Drexel University, and I'll let Bill give a quick introduction.
Yeah. I'm Bill Mihalko. I'm at the Campbell Clinic in the University of Tennessee Health Science Center. I'm a joint replacement surgeon scientist who's been researching in the field for a couple of decades now.
Marco?
Hello, I'm Marco Caicedo. I am an adjunct professor at Rice University Medical Center, Department of Orthopedics, and also part of Orthopedic Analysis, a company that measures immune responses to biomaterials.
Jeremy?
Hi, Jeremy Gilbert, professor of bioengineering at Clemson University and a researcher on metallic biomaterials, tribocorrosion, and degradation of orthopedic implants.
So at the end of the last podcast, we started talking about metal hypersensitivity and the scope and the incidence and risk factors associated with metal hypersensitivity for patients as they make the decision to have a primary total joint replacement. But it's also, metal hypersensitivity is invoked as a reason for revision, a cause for failure, and it's uncertain or unclear how often that occurs. I'd like to hear each of you talk about what you think what your thoughts are about the role metal hypersensitivity plays in implant revision from all 3 of your perspectives. And Bill, do you want to go first from a clinical perspective?
Sure. And we kind of alluded to this in the first podcast that, clinically, when we go through our algorithm, why somebody has a painful total knee replacement, say, once we get to the end of our algorithm, it's rare that I see we're going down that metal hypersensitivity route. And, we talk about, always starting with, is it infected? You have a painful joint that may have effusions that come and go. And there are some symptoms that kind of point us directly towards hypersensitivity, like the cutaneous reactions. Okay, when you see patients who have, kind of this punctate rash that's over their knee with recurrent effusions, and they've been unhappy from day one, that's kind of the first red flag. But we always start with ruling out infection first. And once we've gone down that, we look at instability issues. We look at suboptimal alignment of implants. If their patellofemoral mechanism can cause a lot of this discomfort, and so we want to make sure that the femoral and tibial implants are properly aligned and not causing any type of patellofemoral instability. But once we go down that route, then you go down the metal hypersensitivity route. And, we stated in the first webinar that skin reaction testing is much different than deep tissue testing. And that's why I go the route of lymphocyte transformation test once we get there. But I do think in my practice, at least, that right now I go down that route on a rare occasion, not a common occasion.
Marco?
Yeah, I agree. I think first and foremost, metal sensitivity remains a diagnosis of exclusion. Every other mechanism of failure has to be discarded first. So infection, number 1, mechanical issues. And I think for the most part, the vast majority of physicians, that's what they do. So if infection is negative, if all mechanical issues have been ruled out, and the patient still complains of pain, inflammation, then they tend to look for a metal hypersensitivity. And oftentimes, yes, the patient is metal sensitive. What I can tell you from our end is that the level of sensitivity in some ways is related to the level of pain the patient experiences, especially in the first year or 2 post-op. We have seen, and we published a bit on these in 2017 on JBJS, where up to 2 years post-op, the highest levels of sensitivity were somewhat correlated to the higher levels of pain that the patient was experiencing. Now, when we talk about aseptic osteolysis that is early, that can still be due to a metal sensitivity. I think that it's mostly due to a low perpetual inflammatory response that is mediated also by T cells. But I wouldn't consider that a severe hypersensitivity, which is what you would experience mostly in the first year to 2 years post-op. But yeah, so metal sensitivity, definitely a diagnosis of exclusion. It is not something that is well correlated yet to poor implant performance right away.
Jeremy.
So I'm going to give the metallurgist's perspective here. Cobalt, chromium, molybdenum alloys were introduced into dentistry in the 1920s. In fact, it was one of the first uses for that alloy after development. It's been used in dentistry for partial fixed dentures or crowns or bridges. It's used in spinal devices. It's used in cardiovascular devices. We have almost 100 years of use of cobalt chromium in the human body in many applications where the things we're describing here for these orthopedic implants have not shown up, have not been a focus of the research. And so there's something about orthopedic implants and cobalt chromium alloys that may be a little different than these other places. Even within specific joints of the body, you may see different things going on. Again, now I'm moving out of the metallurgy space, but really in terms of a biomaterial, this alloy has been around for almost 100 years and has served very well in many, many applications. And it was really only very recently, the last couple decades, where some usage of the cobalt chrome alloy led to reactions that were very full, very reactive, soft tissue reactions mostly. And those were new. And before those came from the so-called metal on metal reactions or metal on metal implants. The sense that cobalt chromium and even corroding cobalt chromium would cause problems clinically did not exist. So there's been a progression and a history over time where it was an unrecognized thing. Then we had massive reactions to certain kinds of designs of implants that led to a realization that there was something going on, an association between the degradation of cobalt chromium and these very fulminant sort of reactions. And that only came much later than its use. So, there is a history here. There is some circumstances that have changed to bring to light some of the things we're describing now, but it hasn't always been the case.
So metal sensitivity, how does that fit in with what people consider to be ALVAL, or that is that also, like, what are your thoughts there about is that a conclusive test for assessing metal hypersensitivity? Because it seems like that was what Willert was invoking when he was talking about the early papers with the changes that he was seeing on histology. Marco, what's your thoughts?
Are you asking me?
No, I'm asking Marco, and
Sure.
I'll also
Sure.
I'm asking anybody who has an opinion can chime in here, who's read Willert's
Sure,
work
sure.
and Pat Campbell's work, right?
Yeah, right. So we get into the terminology now where a lot of people describe ALTR, ALTR, as an adverse local tissue reaction, which for the most part can just be your innate immune system, macrophages reacting to degradation products. Now, ALVAL is more specific to a delayed type hypersensitivity. It is a delayed type hypersensitivity, in my opinion, right? Because it involves lymphocytes, it involves macrophages, which are antigen presenting cells. And if you have the migration of lymphocytes to the area of insult, you are experiencing a delayed type hypersensitivity response, especially if you have tissue damage around it. So in my opinion, ALVAL is a delayed type hypersensitivity response. And honestly, any location in which you're going to have both macrophages and lymphocyte infiltrates, that means that you are developing a delayed type hypersensitivity response. Now, having said that, again, these hypersensitivity response is highly dependent on the affinity and the avidity of those lymphocytes to respond to different metal challenge agents. Just because you have some level of sensitivity, it doesn't mean that your affinity and your avidity for that is high. Some patients do have a very high and potent affinity and avidity to either nickel or cobalt or chromium, inducing a very potent inflammatory response that can lead to ALVAL. Whereas other patients may have T cell involvement, but it can just be subclinical, it can be mild, but it can still be a contributor to osteolysis in the long run. So I think that's the biggest, again, misconception in a way, that a metal sensitivity is not binary. It can be subclinical in certain scenarios, or it can be extremely potent in other scenarios.
And
Bill,
so
do you want to
I'll add
comment
some
on
things to that.
can you just look at a revision component in the patient and tell whether they have hypersensitivity or some other type of metal reaction? Or do you have to
Well,
do something, do
that
some other test?
depends. That depends. I mean, first of all, in the hips, when we were dealing with metal on metal, total hips with modular necks, and we were getting MRIs on all these patients because we want to know how much, if there was ALVAL, how much soft tissue involvement there was. So we kind of knew that, and you can kind of see that on the hip side. On the knee side, we'll see metal-laden synovium, but that doesn't tell me that there's ALVAL present. And we're starting to see evidence of ALVAL in these knee revisions that you've shown, and in a lot of these modular connections that we're now doing for revision total knee replacements. But I do think, going back to what Dr. Casado said, I wanted to ask him about the dose response. And, do you think it's really a matter of, we saw a lot of these issues come up because we introduced more modularity, we introduced more sources of metal debris, of whatever type you want to, call that, mechanically assisted crevice corrosion, et cetera. And, do you think that there's a lot of patients out there that are just subclinical that haven't reacted enough to, because their metal ions, their metal wear has not brought them to a level that they're going to react to?
Oh, yeah, 100%. I really think that the burden of metal is a key component of a full-blown metal hypersensitivity. You can be highly sensitive to any specific metal, but if you don't have enough challenge agent to respond to, then you're not going to develop an immune response. And I think that's the reason we saw in those metal on metal hip replacement cases where they were generating quite a bit of metal, that the percentage of people with responses in terms of metal hypersensitivity and pseudotumors was obviously way higher. So, and this is what we tell all of the surgeons and patients that we work with, is that, again, being metal sensitive is not the only component to our response. You need to be metal sensitive, and you need to have enough wear debris to respond to in order to develop our response. So again, this comes back down to component type, patient-specific factors. The patient is sedentary, if it's an older patient that is not likely to generate enough wear to induce a response, then that patient may be okay even if they have a certain level of sensitivity. On the other hand, you may have a patient that is borderline sensitive, but it's a skier, a runner, or a rock climber, and enough debris may be generated so that even that borderline metal sensitivity immunological response may be enough to induce clinical symptoms. So absolutely, I think the burden of metal is the other key component to the response, and it needs to be taken into account.
All right. Well, I'd like to thank everybody for joining us for this second episode. I think in the next webinar, we'll talk more about the kinds of tests you can do to look at whether a patient has metal hypersensitivity before as well as after revision. Thank you all very much for joining us.
Thank you.
Thanks, everyone.